Okay, good evening, everyone. I'd like to welcome everyone to our MSIG webinar, Introduction to Orthobiologics and Advanced Ultrasound-Guided Procedures. We're honored to feature Dr. Taylor North as our speaker for tonight's webinar as he shares his expertise on this topic. The session is geared towards medical students and residents. My name is Kirra Borrello, and I will be serving as the moderator for tonight's webinar session. I'm the current AMSSM MSIG president and a fourth-year medical student at the University of Hawaii John A. Burns School of Medicine. After Dr. North has finished his presentation, I'll be the moderator for the Q&A segment. During the webinar, please enter your questions in the chat, and during the Q&A, I'll ask each question to Dr. North and he can respond. So now it's my pleasure to introduce tonight's speaker, Dr. Taylor North. Dr. Taylor North completed his undergraduate degree at the University of Utah and then earned his medical degree from Edward Via College of Osteopathic Medicine at Auburn. He completed his residency in physical medicine and rehabilitation at the Mayo Clinic in Rochester, Minnesota, and then completed his sports medicine fellowship at Andrews Institute for Orthopedics and Sports Medicine in Gulf Breeze, Florida. He currently serves as a senior associate consultant at the Mayo Clinic Health System in Rochester, Minnesota, and is a team physician at the University of Wisconsin-Eau Claire. His special interests include musculoskeletal ultrasound, orthobiologics, and baseball medicine. Dr. North, please begin your presentation.
All right, thanks, Kira. Appreciate you introducing me and happy to be here tonight. So we are going to dive kind of right into it. And again, the title of the talk is Introduction to Orthobiologics and Advanced Ultrasound-Guided Procedures. Nothing to disclose, no financial relationships. Throughout the conversation or throughout the talk, I am going to reference a few different companies and their individual devices that pertain to the lecture, but no financial relationship with any of them. All right, so just as an overview of what we're going to talk about tonight, we are going to start with defining orthobiologics, and we're going to look at what we know about their mechanism of action. Then, we're just going to scratch the surface, but we will talk about some of the literature and highlight just a few studies that summarize what we do know about biologics. Then we will talk about some of the key regulatory principles and important clinical considerations. And then after that, kind of the back third or so of the lecture, we are going to go into some of the more advanced ultrasound-guided procedures that you might see in sports medicine and orthopedics. All right, so kicking things off, you might hear about this thing in orthopedics that refers to the treatment gap between conservative and surgical management. And it essentially refers to procedures that go beyond our traditional conservative management, but then fall short of more invasive surgery. And I really look at the procedures and treatments that fall within the gap as sort of filling this gap is natural progression of the non-surgical orthopedic world. So just as we see in other specialties, there's natural progression of new developments, new techniques, new treatments. And then we also take maybe some existing procedures or surgeries and find out how can we do them in less invasive ways. So everything that we're going to talk about tonight really fits within this category. And we'll start off going into the biologics. And I felt like to do this, it might help to put some context behind it and use a clinical vignette or case example. And so imagine that you're in, an outpatient sports medicine clinic, and you've got a 48-year-old that comes in. Maybe they say they're a mechanic, some kind of labor-intensive job with their hands, and they've had this right-sided lateral elbow pain for going on a year now, and they've already seen one provider, and the provider diagnosed them with common extensor tendinopathy or tennis elbow. And over the past year, they've done several things. They've maybe done 1 or 2 rounds of physical therapy. They've done a short course of anti-inflammatories. And then they've even tried shockwave therapy. But the pain is still there. And so they're coming to see you and wondering if you have anything that you can offer. So you want to, ensure that the diagnosis is correct. We get some imaging. So we start with x-rays. And, overall, the x-rays, don't show anything too telling. Maybe we do some point of care ultrasound and we're looking at the lateral elbow, specifically keying in at that common extensor tendon. And maybe we see some thickening of some of these tendon fibers with more of a disorganized pattern. We get what's called these enthesopathic changes here, or cortical irregularity, where the tendon is inserting. These are kind of findings of tendinopathy. And so we combine that with our physical exam and we say, well, yeah, I think things do fit. This looks like common extensor tendinopathy. And the patient says, well, okay, I had a friend that recommended stem cell treatment, and I wanted to talk to you about that, see if that would be a good option for me. And so we're going to talk about this term. So stem cell therapy, really, it's just a term that kind of blew up years ago, and these big hopes of being able to consistently regenerate tissue. So this is a picture that was taken from an article published in 2020 in Science News Journal that was discussing the hype around stem cell and regenerative medicine treatments. And, needless to say, the marketing outpaced the research and the evidence that we have. And over the years, we've really tried to shift our terminology from discussing this as stem cell therapy to orthobiologics, as it's a more accurate and accepted term of the therapies that we're actually providing. So with that said, what are orthobiologics? And really the name says it all. This is biologic therapies that are used to treat orthopedic conditions. And the three main ones that we're going to talk about tonight are platelet-rich plasma, or PRP, bone marrow aspirate concentrate, or BMAC, and then microfragmented adipose tissue, or MFAT. And why would we consider using these biologics? Well, we're essentially trying to leverage our body's ability to induce a therapeutic response. Again, the goal is not necessarily tissue regeneration, but more of creating a therapeutic response. And then we ask ourselves, how does this happen? Well, one, with orthobiologics, we're hoping to be able to modulate inflammation, and we'll learn about this more in upcoming slides, but these biologic products, they release these anti-inflammatory cytokines, and that goes on and can reduce local inflammation that then sensitize nociceptors. We're looking to try to improve the joint or tendon microenvironment. We increase local perfusion, we reduce the catabolic enzymes, overall trying to create this healthier chemical milieu. The biologics, they can enhance our body's existing repair response. So what we get at with that is, again, we're not really focusing on tissue regeneration, but more so improvement of tissue quality. And then particularly in cases of tendinopathy, orthobiologics can help break out of the kind of chronic disease state. They do this by helping with tissue turnover, and then subsequently we get stronger tendon tissue and an increased ability to kind of improve their load capacity. So the indications include osteoarthritis and then non-arthritic cartilage injuries, tendon and ligament disorders, muscle injuries, and then there's some other soft tissue situations where you may consider it as well. Okay, taking a deeper dive, going into PRP now. And again, the name kind of says it all. So we've got plasma that's highly concentrated in platelets. And there's maybe some different definitions out there as to what truly constitutes PRP. And we'll talk about this in upcoming slides. But, we can say maybe somewhere between 2 to 6 or 3 to 5 times the whole blood platelet concentration is what would maybe constitute, adequate PRP. Again, more on that in upcoming slides. But how do we go about doing this process? So it starts with, if you look at the picture on the right, we start with venipuncture or peripheral blood draw. We take out whole blood. We put it into a centrifuge that then just spins down and separates out the different components of whole blood. You then take the PRP and inject it under imaging guidance into the site of pathology. All right, so once you inject it, what is actually happening? Well, the platelets, once injected and activated, they release cytokines, they release growth factors that go on to regulate the phases of healing. And we're hoping to achieve this through one, the promotion of angiogenesis, chemotaxis of reparative cells, and then immunomodulatory activities. Okay, so this is a picture that was taken from an article published by Everts et al. Back in 2020, discussing the therapeutic considerations with platelet-rich plasma. And it shows activated platelets and how they release these growth factors and adhesion molecules that then go on and really perform various cell-to-cell interactions and communications. And this then goes on to produce these immunomodulatory effects. So if we kind of go back to our case of tendinopathy, we'll look at this illustration here, which shows the different phases of tissue healing. So first we have the inflammatory phase, followed by cell proliferation, eventually moving into this tissue remodeling phase. And when we talk about cases of tendinopathy, the damaged tendon gets stuck in this process and doesn't undergo adequate tissue remodeling. So when we do something like inject PRP into a tendon, we're trying to, for lack of better terms, hit the reset button here and restart the phases of healing, hoping to push, beyond proliferation into tissue remodeling and then obtain a satisfactory degree of tissue remodeling. So again, applying that to our case, would PRP be a reasonable option in this situation? And the answer is yes. The patient's tried several things up to this point, and it seems like a reasonable thing to do. So we can do this again. It's done in office, and the image on the left is just showing the common extensor tendon with a blue box around it. The blue box is depicting the orientation of the ultrasound transducer. And then the white arrow is depicting the direction that the needle would be coming in. We call this in plane with the ultrasound transducer. So on the right, then the ultrasound image that we're seeing, you see the nice kind of needle shaft coming in and able to deliver the platelet-rich plasma directly to the site of pathology with precise accuracy. Okay, so with that background, then we say, well, what does the literature show? This is just one of several studies looking at PRP for tendinopathy, but it's a meta-analysis that was published back in 2017 in AJSM. And this meta-analysis included 18 different studies with over 1,000 subjects, and they were looking at PRP versus other treatments for different tendinopathies. And the other treatments they were looking at included corticosteroid injections, saline injections, local anesthetic injections, and then dry needling. The primary outcome was patient-reported pain scores, and they found that leukocyte-rich PRP was superior to the other therapeutic modalities. Well, what about PRP for osteoarthritis? We mentioned that that was one of the indications. Again, one of just several studies out there, but this is a recent systematic review and meta-analysis published in AJSM, authors coming out of HSS and Mayo Clinic in Rochester. And they were looking at PRP versus alternative injections for knee osteoarthritis. Other injections included corticosteroid and high hyaluronic acid, or HA. And the outcomes, again, they were looking at patient-reported symptom improvement, and then they were also looking at any need for further intervention, which subjects went on to undergo some sort of reintervention in their follow-up period. And they found that PRP had a significantly higher rate of successful outcomes. And again, this was determined by fewer cases needing to undergo reintervention, and then more subjects reporting pain improvement. Now, good studies, but we kind of take a little pause here, and I think this is a very important slide that really determines a lot about PRP outcomes. And what's important to note is that PRP, I want you to think of it, that it is not a single product per se. It's, there are numerous preparation protocols, there are variable kits and systems out there that are used that inherently lead to variable end products. And then these go on to impact the clinical outcomes. So key variables when we are preparing PRP, again, include what type of system or kit we're using, what the whole blood volume is that we're starting with when we do that blood draw. We talk a lot about leukocyte content in this space, and if we use leukocyte-rich versus leukocyte-poor PRP, and these are settings that can be adjusted on the machines. And then we want to know what is the overall platelet count or platelet concentration that we have in our end product. And what we do know is that dose matters. And then also, you can look at, are we using any type of activation method, which sometimes will be included with protocols. And essentially think of it this way. So you've got patient that walks into clinic A, and they say they receive a PRP injection, and then you have patient that walks into clinic B, they receive a PRP injection, and it might be for the same thing, let's say knee arthritis. Well, these products, we don't know if they're necessarily the same end product. And because of these variables, it has led to some heterogeneity in the literature. So not every study out there shows clear improvement following PRP. Now, when we take maybe the aggregate of the high quality studies, certainly more favorable than unfavorable, but it's still important to mention. And the heterogeneity that we see in the literature, again, is coming from this inherent variability that comes along with PRP preparations. So I think it's important to critically analyze studies and see how they might be addressing the variables here that are listed, and then see how it might impact the results. Because it is challenging to otherwise draw conclusions, say if some of these details are maybe not listed in the study, or maybe if we look at it and we say, well, gosh, they're missing this part. And so that's just an important thing to look at when we're talking about PRP literature, really orthobiologics in general for sure. So the take-home point with this slide is PRP, it is not always a singular therapy, but more a category of biologic products. And then when discussing these products and interpreting the literature, again, we should be focusing on the overall biologic composition rather than just the label of PRP or the title of PRP. All right. Now, with that said, we are starting to learn bit by bit more on how we can optimize our PRP preparations. So this is a recent meta-analysis, again, coming in at AJSM, that was looking at PRP for knee osteoarthritis. And again, conclusion shows, PRP did lead to functional improvements as well as pain relief at both short and midterm follow-ups in this study. But more importantly, they came to this conclusion that, hey, the concentration matters here. And they were seeing that higher platelet concentrations were associated with superior results. And then we take these three studies that maybe go a step beyond that and say, well, gosh, maybe beyond concentration, we should be looking at the overall platelet dose and the platelet count. So they found that the total platelet dose is more predictive of outcomes than just the fold changes in concentration alone. So in other words, there is potentially a dose-response relationship between the platelet dose and the clinical effectiveness. So again, with this in mind now, we kind of start to adopt this mindset that maybe PRP, it should be treated more like a drug where we need to optimize the appropriate dose. And then once we do that, we figure out, well, what are the protocols, what are the systems that allow us to achieve that product for better results? And now, kind of moving on from PRP, we'll talk about some of these cell-based therapies, specifically BMAC and MFAT. I'll explain why I refer to them as cell-based therapies. But BMAC, again, stands for bone marrow aspirate concentrate. And then MFAT is microfragmented adipose tissue. And these are just illustrations of how our products are harvested. So how do these work? Well, through the promotion of angiogenesis, chemotaxis of reparative cells, modulation of inflammation, and then stimulation of matrix synthesis. Now you say, well, this looks a whole lot like what we talked about with PRP, and that's because it is. There's a lot of overlap with how these biologics work. But now where PRP is primarily working by, you deliver this big concentrated burst of growth factors and cytokines, and then that goes on to really work by cell signaling and cell communication. BMAC and MFAT, well, they share some of that cell signaling property, but they also add additional mesenchymal stromal cells, or MSCs, as well as progenitors that are proposed to have additional paracrine and immunomodulatory effects. So MSCs, you have maybe heard of these in this context referring to mesenchymal stem cells, but again, we're shifting terminology as it pertains to orthobiologics to better reflect what we actually understand about these therapies. And again, avoid overstating how these products actually work. So we say stromal cells rather than stem cells. And again, that's because the main role remains paracrine signaling, not full tissue regeneration. And down here at the bottom of the slide, Arnold Kaplan, who was a pioneer in the space of MSC use in humans, even coined this term medicinal signaling cells, and maybe was thinking that's a more accurate description of these drugs you could think of them as that we're actually providing. Okay, so BMAC, this is what the procedure looks like. Again, we start just as the name says, bone marrow aspirate. So we start with harvesting bone marrow, typically from the pelvis. Once you harvest the bone marrow, much like PRP, it's placed in a centrifuge, spun down, separated. You take your end product, inject it under imaging guidance to the site of pathology. Okay, what does the literature show for BMAC? Again, this is just one of the studies. Certainly, though, when you look at the literature as a whole, it is less robust than what we have for PRP. But this is a systematic review that was published in AJSM. It was looking at BMAC for knee osteoarthritis. And they found at the end that BMAC was effective in improving pain scores as well as patient-reported functional outcomes. However, it did also look at it compared to PRP, and it did not necessarily outperform PRP. And MFAT was also studied, and quite frankly, the BMAC again showed these beneficial effects, but did not outperform the other two treatments. So then we move on to MFAT, and we'll learn a bit more about that. Again, this is autologous fat that's mechanically processed. This is an image that was taken from the Lipogems website. This is a company that has these MFAT kits and processing systems. But basically, if you look at the image on the left, again, you start with a lipoaspiration or fat harvesting from the belly or flank. The adipose tissue is then processed, washed, and rinsed, leaving you with your end product at the end that's ready for injection. Okay, so what does the literature show for MFAT? Well, on the left, we've got a study from Mike Beria and the team at Ohio State. This was a level 1 randomized control trial where they were comparing MFAT to leukocyte-poor PRP for knee osteoarthritis. And they found that both groups demonstrated statistically and clinically significant improvements in both pain and functional outcomes at the 12-month mark. However, they did not find a difference, again, between both groups. Again, going back to this principle that maybe there's therapeutic equivalence, at least in this study, therapeutic equivalence between MFAT and leukocyte-poor PRP for knee osteoarthritis. And then on the right, we've got a study by Ken Motner and Robbie Bowers and their team at Emory. And this was a prospective study looking at MFAT versus BMAC for knee osteoarthritis. And again, found both groups. They did produce significant improvements in pain and functional scores. However, again, no significant difference between the two groups. Again, getting back to this point of therapeutic equivalence. So in summary, BMAC and MFAT, they may have therapeutic benefits, but maybe based on some of the literature that we have, it's unclear if it is definitively better than PRP. Now, there's certainly some nuances as to specific indications, but this at least is somewhat of a summary of what we know right now. Okay, so we're going to wrap up the conversation on orthobiologics, just talking about some of the regulatory basics and how we use these therapies responsibly in practice. This is kind of a terminology slide, but maybe some principles that are worth understanding, especially when you're having conversations with patients if it's brought up. But talking about FDA regulation, so the devices that we use to prepare these orthobiologic products are considered FDA cleared. However, PRP, MFAT, and BMAC are not considered to be FDA approved biologic drugs. So what does that translate to? Well, these essentially are these regulated products that can be used in clinical practice, but they have to meet this criteria first of undergoing minimal manipulation and then being used for homologous use. Minimal manipulation essentially means that the tissues are processed without altering the original relevant characteristics. And then homologous use, saying that the product is going to be used to perform the same basic function in the recipient as in the donor tissue. So again, sometimes they'll come in and just, maybe we'll talk about, well, is this something that we can actually do? Is this legal, illegal? But there's nuances for sure, but try to just get that point across here. And I think this is important to talk about too, again, as we translate this to clinical practice. In 2021, this paper was published by, if you look at the author list, there are several leaders in this space in our country, and they're trying to give recommendations regarding the responsible use of orthobiologics in clinical practice. And to summarize some of their recommendations, they, say, well, we should start first with established and guideline supported therapies. We should only be using products and procedures that are allowed under the current FDA guidance. When talking with patients, certainly be clear with the description of the procedure and then setting realistic expectations. Use appropriate equipment. This goes everything from the systems and kits we're using to come up with our biologic product, and then again translating that over and using ultrasound or imaging guidance for the procedures. We should avoid hype or implying results that are not supported by the literature. And then finally, as always, above all, ensure patient safety. Okay, so shifting now to the kind of latter half here of the lecture, talking about ultrasound-guided procedures or advanced ultrasound-guided procedures. And I know previous talks over the past few weeks have been on the use of ultrasound, and this piggybacks off that, but we say, why would we use ultrasound in practice? Well, it allows for real-time targeting when it comes to procedures. So we can guide a needle or a device directly to our target with precise accuracy. We can avoid important neurovascular structures and then minimize any tissue trauma. So ultrasound-guided procedures in orthopedics, it really follows a similar trend that we've seen in other specialties, such as, use it, for example, interventional cardiology, interventional radiology, where we use imaging guidance to come up with less invasive procedures. So again, we've translated this over to orthopedics. We can do things with smaller incisions, which leads to, again, less tissue disruption, with the overall goal of faster recoveries, improved patient outcomes, and then thrown in is reduced healthcare costs. So some of the advanced ultrasound-guided procedures, we'll talk about most of these here, but a percutaneous needle tenotomy or fasciotomy, something called tendon scraping or tendon high volume injection, calcific barbotage for calcific tendinopathy, a nerve hydrodissection, and then even tendon and ligament releases. Okay, so first up is ultrasound-guided needle tenotomy, and we say this can be performed with either a large gauge needle or a specific device. In the bottom left corner, I have an image of a Tenex device. This is just one of several devices out there. And how this specific device works is at the needle tip, it creates these high frequency oscillations that selectively target the damaged tendon tissue. And then it has this two-way irrigation and suction system, kind of irrigating in with sterile saline and simultaneously suction so that the small little fragments of damaged tissue can be removed in real time. Again, there's other devices out there, each with their own individual nuances. And again, this can also be performed with just a larger gauge needle alone. And some of those mechanical fenestrations, you just physically create mechanical fenestrations through the tendon. And this mechanical disruption occurs at the degenerative tissue. Blood products are brought in along with their growth factors. And again, if we refer back to the image here of the stages of tissue healing, the whole goal with that is, again, we're trying to get that tendon out of the stuck phase and push beyond that and achieve this satisfactory degree of tissue remodeling. So what are the indications? This can be used for chronic tendinopathies, calcific tendinopathies, and fasciotomies, such as plantar fasciitis. And these ultrasound images are just kind of really zoomed in on a tenotomy for patellar tendinopathy. And on the top image, the arrows are pointing to an 18 gauge needle that's being directed under ultrasound guidance to kind of the deep fibers of the proximal patellar tendon. And then the bottom picture just shows the difference under ultrasound of what the 10x device looks like. And you can see just a little bit larger and has some of these kind of hyperechoic reverberations coming behind it. But that's what that looks like. So if we go all the way back to our starting case of common extensor tendinopathy, uh, and applying it to this needle tenotomy principle, well, oftentimes when we are delivering PRP to the site of a tendon, we will perform that needle tenotomy as well as we're delivering or injecting the PRP. And so again, we refer back to our image on the left. It shows the blue rectangle showing the orientation of the ultrasound transducer with the arrow showing which direction the needle's going in. And then the needle kind of comes in, and again, multiple fenestrations directed right at the site of injury, and then can inject the PRP at that time. Okay, another procedure that we'll talk about is ultrasound-guided calcific barbotage or lavage procedure. And this is a procedure for calcific tendinopathy. And calcific tendinopathy is just a form of tendinopathy where calcium hydroxyapatite deposits within the tendon tissue. And then that can lead to acute inflammatory flares or even chronic mechanical pain. And so what this procedure looks like, if you look at the illustration on the left, you have a needle that's attached to a volume-filled syringe, typically composed of sterile saline and then a local anesthetic. The needle is introduced into the calcification without penetrating the posterior wall, so that part's important. If the needle can enter that calcification but not penetrate the posterior wall, then it acts as this enclosed pressurized system. And then the injector lightly pulses on the plunger of the syringe, injecting into the calcification. But because it's this enclosed space, it creates a negative pressure. So as you push or plunge in and the plunger returns on the syringe, the negative pressure can bring the calcifications along with it, essentially sucking them out into the syringe. And so this is a video of that. This video or ultrasound image corresponds to what we're seeing on the left. We're looking specifically at the supraspinatus, and we've got the needle coming in from right to left. This, I don't know if you can see it here, right here. This kind of ring of tissue is that superficial border of the calcium deposition. And hard to make a lot of sense of what's going on, but right there, I'm kind of plunging in or pulsating in again on that plunger. And then that, as the plunger returns, some of that calcification is removed and broken up into smaller pieces. All right, so the next procedure that we're going to talk about is an ultrasound-guided tendon scraping or tendon high volume injection. And this is used for the treatment of specific tendinopathies, mainly Achilles tendinopathy and patellar tendinopathy, when there's cases of increased neovascularization. So if we look at the ultrasound image, it is what's considered, again, a long axis view of the Achilles tendon. So up here is the tendon running from left to right. And deep to the Achilles tendon is Kager's fat pad, which is highly vascular. And in certain cases of tendinopathy here, there will be this neovascularization that kind of sprouts up from the undersurface. And there's evidence that nerve structures within the peritendinous tissue that are associated with this with the neovascularization, that they contribute to the pain. So with this procedure, we can use a specialized needle that under ultrasound can be guided directly at that tissue plane and inject a large volume of fluid that essentially creates a mechanical separation. And then you can move the needle, I'll show it in upcoming slides, but essentially move the needle downward and back and forth, again, further creating a mechanical separation, somewhat severing that neovascularization, thereby reducing pain. All right, so this is what it looks like. Again, image on the left, blue triangle, showing the orientation of the ultrasound transducer. And this is looking now at the Achilles tendon in short axis. So on the image, This is the Achilles tendon that's coming out at us in the screen, kind of running in and out of the screen. Coming from right to left is the needle. The tissue down here, again, is that Kager's fat pad. And you can see, again, the needle can be directed very precisely between those two tissue planes. And as it's injected in, or as it's entered in, you'll be injecting fluid to create some of that mechanical separation. And then the image here on the right shows you this kind of, oh, whoops, let me go back. Let's try that again. All right, so again, the needle's now in place. You see pushing down, creating further mechanical separation of the underlying fat pad. Now if we rotate, so ultrasound transducer, now showing a long axis view of the tendon, which we're seeing here. With that said, now that we've rotated, we're no longer seeing the needle shaft in plane with the ultrasound transducer, but we're seeing it perpendicular to the transducer, which we refer to as out of plane. So it's this white needle tip right here that's underneath the Achilles tendon and sitting on top, again, of the fat pad. And what this, oh goodness, it did it again. What this video shows is what we call, sometimes we'll refer to as a windshield wiper effect. So not only can you press down on the fat pad to create separation, but again, being able to use Doppler with the ultrasound and target that neovascularization, you can then enter in and kind of go up and down or right to left, creating this windshield wiper effect, further creating that mechanical separation. All right, the next thing we'll talk about is an ultrasound-guided percutaneous fasciotomy. And this is used for chronic exertional compartment syndrome, which is a condition characterized by increased intracompartmental muscle pressure that occurs after exercise, and it typically leads to pain and sometimes neurologic symptoms. Now, the definitive management for this is a fasciotomy, and traditionally this has been performed in an open fashion that can lead to a large scar and longer recoveries. Now, doing this under ultrasound guidance has been described and is being done at some places. And the image that I've got here on the left, the bottom left, is an ultrasound image that was taken from a paper published by Jonathan Finoff and Wade Johnson. And they describe the technique for performing this procedure. And you use a meniscotome, which is shown up here. It's essentially a V-shaped cutting device. All right, so down here, V-shaped cutting device. And under ultrasound guidance, it can be directed down to the subcutaneous tissue, shown here with the white arrows. And the star is showing the cutting tip, and then the dark arrows are showing the fascial plane. And I've heard Dr. Finoff refer to this, they're using this analogy that as that meniscotome is pushed through that fascia, it is much like scissors cutting through wrapping paper. If you open scissors and then just glide them along that plane and how it slides right through. Similar analogy that can be applied to this procedure. Okay, we'll talk a little bit about ultrasound-guided carpal tunnel release. Carpal tunnel syndrome, a compressive neuropathy of the median nerve at the wrist. Definitive management includes surgical release of the transverse carpal ligament. And traditionally, this has been performed with either a mini-open or endoscopic technique, but can be done under ultrasound guidance. And some of the benefits with ultrasound, again, it includes first, when we're referring to this procedure, it lets us see underneath the skin. We can point out where we're going to be making cuts. So we see then cut rather than cut and then see. Again, very, very small incisions here or even poke holes. No sutures needed, all done under local anesthesia, does lead to quick recoveries. And again, all of that translates to reduced healthcare costs. Okay, so this is what the procedure looks like. Pause that, we'll come back. Now, specifically on the left, this is one of the devices from Sonics Health, and I should go back and explain this. So there's several techniques that have been described in the literature. Two that I've got shown here. First on top, this is an illustration here using what's called the thread carpal tunnel release, or a cutting thread, and it's a technique that was described by the Go brothers. And then the image on the bottom, this is a device created by Sonics Health, and that is a company that specializes in ultrasound-guided procedural or surgical devices. And now the image that I've got here on the left is one of the older models of the cutting knife from Sonics Health. But you can see under ultrasound guidance, it's guided from proximal to distal at the wrist. And what that translates to is the image on the right showing the device here coming from right to left. And what this is essentially it has a kind of retro blade cutting knife that is recessed within this device. And then again, so when you enter in, everything's blunt. And then once you are in position, you can deploy the knife and then physically retract it back and it cuts through the tissue. This tissue right here that we're seeing is the transverse carpal ligament. And so that's the target. And again, the device is in place, the knife is deployed right here, and then slowly retracted back through the transverse carpal ligament, cutting and releasing that tissue, performing the release. Okay, so we're going to finish up last one here and talk about ultrasound guided trigger finger release. Much like carpal tunnel release, we have devices to perform this procedure, but trigger finger is also known as stenosing tenosynovitis, and it's where we develop this thickening of the flexor tendon or pulley system, most often the A1 pulley, and this pulley system helps kind of anchor those flexor tendons down to bone. And when we get thickening, it can create painful locking or actual triggering of the finger where it gets stuck, catching, etc. And to perform this procedure, there's a couple, again, different devices up here on top. This right here is called a no-core needle. It's essentially a needle with a tiny scalpel or cutting tip. And then the image on the left, again, is a specialized device from Sonics Health. And under ultrasound guidance, the device is entered in underneath the A1 pulley. And in a similar fashion to what we saw with the carpal tunnel release, a retrograde kind of cutting device is deployed once in position. Up here that I'm circling, this is that A1 pulley. The knife is deployed and then retracted back, cutting through that pulley tissue, performing the trigger finger release. All right, so with that said, we'll wrap it up by just summarizing what we've talked about. So orthobiologics, first, they are increasingly being used more and more in sports medicine and orthopedics. As we expand our knowledge on what we know, we need to continue kind of optimizing those key variables that I discussed. That will lead to improved patient outcomes in the end. Regarding ultrasound technology, it certainly has come a long way over the past couple of decades and is now allowing us to do more and more of these ultrasound guided procedures. As with anything, as it pertains to orthobiologics, or you can apply this to anything that we do in medicine, but patient selection is key, and then always using evidence-based practices, and then above all, patient safety should always remain our highest priority when considering these procedures. Several references, and want to thank you all again. And if there are questions, I think we open it up at this time, and I'm happy to help out.
Yes, thank you so much, Dr. North, for that presentation. Was really great. So we will be moving on to our Q&A segment now. So please type any questions in the chat. And again, just want to thank Dr. North for sharing his expertise with us tonight. So first question, I believe from earlier, asking, do you have a lot of chiropractors in your area offering Hylogel, which I guess is amniotic stem cell plus some other stuff in there?
Yeah, I do. That does get brought up fairly often, and I think what I would say is I take all of it as a case by case. I try to ask patients about what conversations they've maybe, and if you're referring to, like what happens frequently with me is where somebody might come in and say, like much like the case that we saw, where they'll say, hey, I saw another provider, they talked about this, or I, maybe heard through the grapevine that they're doing this and that over there. And, I guess I take it case by case. I try to hear out what the patient might be aware of, what kind of things were talked about with them. And I guess in short, what I just try to say, I try to promote our practice and the way that we do it more than kind of focusing on others. And so I just say, we, base what we're doing off the literature that exists out there. We use the PRP system and protocols that have been studied and in the studies that have shown to be the ones producing the highest level of outcomes. And so, with that in mind, again, I think I kind of point all the emphasis on just our practice and say, hey, here's what we offer, rather than kind of talking about other practices. And I don't know if that necessarily answers your question, but the answer to that is yes, it comes up often. And I just kind of try to point people back to the evidence. And again, and that's why maybe understanding some of the FDA regulations and so forth is important because it certainly helps when we're talking with patients about these situations.
Thank you. Next question is, when would you choose BMAC or MFAT over PRP? As you mentioned, the evidence shows similar outcomes.
Yep. Again, case by case. And what I will say is I do significantly higher cases of PRP. And depending on the case, again, with the most common being the most common, things like tendinopathies and osteoarthritis, um, I'll talk to them. There's many things that come into it, right? It's more than just the condition that we're treating, but there's other factors. One, the financial obligation that comes along with it. So these are typically going to be out of pocket cost procedures. And so in our practice, PRP is significantly cheaper. So if I think that maybe the outcomes, let's say we're treating knee arthritis, is going to be equivocal, then I might be kind of at least saying that, hey, here's what we know again about the studies. PRP shows this, BMAC shows this, MFAT shows this. Some of these other procedures, again, theoretically have some of these mesenchymal stromal cells and more kind of this, cell signaling, or more than beyond just a cell signaling response, but still kind of going back to the literature and ultimately using that and then maybe the patient factors like out of pocket costs and so forth to make that decision. But I'd say overall, vast majority of times, I'm using PRP as the first orthobiologic that I'm going to for those exact reasons. Cheaper, and then the evidence is much more robust with it. And again, don't definitively know in most situations if the BMAC or MFAT are superior to PRP. Um, so certainly some nuances. You'll have patients that might come in and are specifically looking for one or the other. Maybe they've had PRP in the past and they've talked to somebody else about BMAC and they're saying, no, I've kind of already came to the conclusion I want to try this. So at that point, you just make sure that it's actually clinically indicated and safe, and then that might be a reason to proceed.
All right. Next question. Um, how about D5W versus PRP for plantar fascia and Achilles tendon? And also, what are your thoughts on ERCP/shockwave for calcification?
Man, yeah, really good questions. I think overall, to summarize those, all of them I think are reasonable things to do. There are studies out there that would support maybe all of them being used. So again, coming down to which do you select? I can't say that I know of enough literature out there that shows one to be superior to the other. So then again, we kind of take into factors, what are the costs? You bring in something like shockwave and you say, well, shockwave is non-invasive. So if we're looking to kind of go in this least invasive to more invasive, fashion or algorithm, then that might be a good starting point. But I think to answer the question, potentially all good treatments, um, probably all have reason to pursue each of them. But then you just use those other factors, cost, explain the procedure, what the recovery might be like, and then allow the patient maybe to help with the decision making on what seems to be the best option.
Okay, next question. For some of these cutting edge procedures discussed, particularly ones based on fascial disruption, how robust is the body of literature for results? Is it considered standard of care now?
Um, I wouldn't say it's considered standard of care, and there's probably multiple factors that go into that for sure. I guess I can speak to. I mean, yes, a lot of there is literature for each of those procedures I talked about. There are certainly studies talking about each of them, and I guess the short answer is probably not considered the standard of care. Again, many factors that go into that. This is still considered relatively, new territory, and certainly should be things that are done on a collaborative effort with our surgical colleagues. And so because of that, I think you can still, while several of these, and I'm maybe I'm excluding Tenex from this, or the needle tenotomy. That has been around long enough to that is maybe you could consider that as part of a treatment option for the standard of care. But some of the other more advanced things with tendon and ligament releases, it's going to be kind of more situational based and maybe even institutionally based as to what the true standard of care is.
Okay. Do ultrasound-guided carpal tunnels still require an OR to perform, or can they be done outpatient in clinic? Also, have you heard of any similar technique for Guillaume's canal?
Yeah. So the first part of the question, this can be performed in an operating room, outpatient procedure suite, or in a clinic. A lot of that again comes down to individual practice setups, but it is at least designed to be able to be performed in an outpatient clinic. The second part, so for Guillaume's canal, not specifically that I know of for that condition. You can apply some of the principles with ligament releases and apply them to other parts of the body. Not that I've seen in particular for Guillaume's canal. And we see that one in clinic less. It's less common of a pathology, and so gonna have kind of maybe lower on the totem pole as far as people that are looking into this is like what should we look at next as far as what we can do.
Next question is, how expensive is 10x or 10jet? How many patients do you need to make the cost worthwhile?
Good question, and I honestly, unfortunately, I don't think I can give you a good answer on that. The billing, that's I think probably not that I'm trying to evade the question here. One, I don't actually know the definitive answer because it's going to come down to each individual practice. So for us at Mayo, how we bill for it, we essentially have built-in systems to our EMR where we put in the description, where we essentially just order the procedure to be done. It gets sent to our billing team. But the topic of billing codes for 10x is certainly a topic of discussion. And it is somewhat institutionally based as to what the cost is, what the insurance coverage is, and therefore translating it to what that looks like from a revenue standpoint in practice. So I don't have a specific answer to give you to that. It's a little more nuanced than just saying it charges this much or it bills for this much right now, and you will earn this much because it's really going to come down to the practice environment.
What sort of training would you recommend for residents who are interested in becoming proficient in these procedures?
Yeah, it's practice, 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 practice. So any way that you can achieve practice, and I would say high level practice. So um, you know, certainly courses at AMSSM. I think if you can go to AMSSM, that's a great opportunity. There are several ultrasound courses the um, throughout the course that have basic level up to advanced levels, and really you're kind of putting together a lot of the top sonographers in the world in this space uh, at that meeting and teaching, and so I think that's a great place to start. There's some online resources, textbooks that are also fantastic, and um, I'm happy to, I mean, if we need to get more specific about it, I'm happy to share those recommendations with you. But I'd say practice, but practice in a good way and the proper way. And if you're kind of starting from scratch, then there's a few textbooks that I'd recommend, and courses. Courses if you're kind of getting your feet wet. And then if you're going into sports medicine and you truly want to do more with ultrasound, then certainly sometimes selection with your training programs comes into play with that too. And you just try to get as much practice and good practice as you can. And then I'll tell you, I mean, I'm not too far out into my practicing career, and it remains to be a very humbling skill set. And I'm doing it every day and continue to grow a ton with it. So it's just practice and time.
Is there any prep that you advise your patients prior to orthobiologic injections, for example, stopping medications, increasing hydration, or certain diets? I've heard NSAIDs need to be stopped for PRP, but does that also apply to the other cell-based therapies?
Yeah, excellent question. And the answer to that is yes, especially with NSAIDs. So a couple things, some of the GLP-1 agonists too, that like Ozempic and so forth, some kind of recent things that we should, um, you have the conversation at least with the patient as to whether or not you stop that or not. But maybe some kind of new emerging evidence that that may interfere with our orthobiologic therapies. The same goes with NSAIDs. So yes, you do want to try to stop these for a period of time before the procedure and then after. And again, we're trying to give the platelets the best chance that they can to go on and do their thing. And so if we're taking medications that maybe interfere with their production, we might not get the level of success or results that we want to see. More on diet. Yeah, there's certainly something to that. Again, I think with what we know, we can maybe simplify it and generalize it and say anti-inflammatory diets. So, take that for what you will. But whole foods and less processed foods. Again, what is the overall impact of the clinical outcomes? We maybe don't know fully, but there is some reason to think that having an anti-inflammatory diet or so is beneficial. And then I can't remember, was there something else with the question that was asked?
I think the other
Medication.
aspect was increasing hydration.
Oh yeah, increasing hydration. Well, I'll tell you that helps with the blood draw. Sometimes we're taking pretty large volumes of blood. We always tell patients to come hydrated, and a big part of that is for the blood draw. But yeah, certainly, I think there's probably something to that, right? I think probably following general what we call health principles and nutrition principles would only help your chances with the outcomes. But so yes to the diet changes, it can only help. Yes to hydration, and then yeah, there are a few select medications that we maybe talk about avoiding prior to performing the procedure.
Okay, great. I believe those are all oh, one more. Any specific contraindications to PRP or cell-based therapies?
Yep. So there are some maybe strict contraindications or absolute contraindications, and then some relative contraindications. So things like blood-based cancers, leukemias. Maybe a discussion that you would want to have again if this is something that is in the kind of active phase, then I mean for me that's a big contraindication. If it's maybe a history of, it's a conversation that I have with oncology. Um, and then so I think not only just bloodborne cancers, but I think cancers in general. If I have patients that have cancers or maybe they're undergoing chemotherapy or other types of treatment, I will reach out in those situations that are maybe gray areas where we don't fully know, and I'll run it by those providers and say, hey, here's what we're doing from your end. Are there any risks associated with this procedure? So those are big ones that I'm thinking of. And then some of the other things that would fall into it apply with just other standard injections, and it sounds basic, but cellulitis or skin infections at the site, knowing if it's PRP or something, if you're going to be doing a tenotomy with it, and you want to make sure there's no allergies to things like lidocaine or local anesthetics. But so yeah, there are a couple of those maybe absolute contraindications, and then several relative contraindications or things that you might need to consult on before proceeding.
Okay. Um, let's see. Is there anything you're personally curious about or looking into regarding orthobiologics or these procedures?
Um, Yeah, I mean, personal interest kind of in all the above, and both are a huge part of my practice. As far as current research goes, I'm not actively involved with something pertaining to one of these, but have been in the past, um, specifically with some of the ultrasound guided procedures. So, yeah, but I would say all of it is a big interest of mine. And this talk really encompasses a lot of what I talk about with patients on a day to day basis.
Okay, great. So I believe that was all of the questions. Before we conclude tonight's webinar, I want to express our gratitude to Dr. North again for taking time out of his evening to share his expertise in orthobiologics and advanced ultrasound guided procedures with us medical students and residents attending tonight's session. Thank you to everyone who attended tonight's webinar as well. I want to encourage everyone to join us next Tuesday, December 16th at 8 p.m. Eastern Time for the last MSIG webinar for this year. It will be the third webinar of this three-part series on sports ultrasound and orthobiologics hosted by our medical student interest group. This three-part webinar series has built from one session to the next and culminates in the webinar session next Tuesday for an interactive Jeopardy game where charter medical schools connected to the MSIG have been invited to register a team of current medical students, and it'll have a team captain and up to four members, and they'll compete against other charter medical schools in an interactive Jeopardy game. There will be questions on sports ultrasound basics, anatomy of the shoulder, knee, and hip, and questions on orthobiologics and ultrasound guided procedures like we learned about tonight. At the end of this 1 hour interactive Jeopardy game, the medical school interest group team with the highest number of points will be the winner and will be given the opportunity to host an MSIG webinar in 2026. They'll select a sports medicine topic as well as faculty from the medical school that are AMSSM members to be featured as the webinar speakers. All AMSSM member or student members should receive an email from Joan Brown, AMSSM membership manager, with the link to register your med school interest group team for the interactive Jeopardy game. All team registration forms must be submitted by next Sunday, December 14th, to be contestants in our MSIG interactive Jeopardy game. So it's with pleasure that we'll announce that Dr. Ravin Patel and Dr. Giorgio Negron will serve as the co-game hosts, along with Jenna Suzaki, who's a AMSSM MSIG officer, as the moderator for the interactive Jeopardy game. So we hope you will join us for our exciting year-ending Jeopardy game. It has been my pleasure to serve as the moderator for tonight's webinar, and this concludes the webinar. Thank you again, Dr. North.
Yeah, thank you all.